And welcome to the Dr. Bob Show. Have you ever had any trouble with your hands? Do your hands bother you? Do they ache? Have you got little lumps or bumps in your hand? Have you ever stoved a finger? Do you think you have arthritis of the hand? Is it in the far part of the hand or the close part of the hand? Does your wrist bother you? Sore wrist? Have you strained your wrist? Have you tried to pick up something and your wrist hurt and it wouldn't let you pick up something? We're going to be talking about on this show, and my guest is Dr. Tim Renfree. Dr. Renfree is a board-certified orthopedic surgeon who deals just with the hand, wrist, and upper extremities, including the elbow. He'll be answering our questions. Hello, I'm Dr. Robert Overholt. I'll be your host for the next 30 minutes on the Dr. Bob Show. Later on, we'll be talking about a bummer for a nose, a bad nose. Do you have an allergic nose? Do you have a runny nose? Does pollution bother your nose? Or do you have a sinus infection? Vasomotor rhinitis, allergic rhinitis, rhinosinusitis, gustatory rhinitis. Whoa, a lot of nose problems. We'll be answering those, and you'll be shocked at some of the symptoms you have. We're talking with Dr. Tim Renfree, board-certified orthopedic surgeon, deals just with the upper extremity, the wrists, the hands, the fingers, the elbows, and we're going to be talking about multiple possibilities. Tim, welcome to the Dr. Bob Show.
Thank you for having me.
Tell me about the palm of the hand. When somebody, I'm hurting here, what do you think of?
So most common things, obviously trigger finger, and people say, well, what's a trigger finger?
What's a trigger finger?
So mostly tendonitis.
What's a tendon?
Tendon, oh, great. So a tendon, muscle in the forearm, attaches to a tendon like a rope, pulls the pulleys.
Yeah.
So there you go, you clasp your hand. The tendons in the palm run through a series of tunnels called pulleys. So as you grip, oftentimes heavy gripping can create some swelling. So the tendon and the pulley then rub, create more swelling. So that's the most common thing we'll see.
Where does it usually occur? Where is that?
The thumb's
irritation?
the most common.
The thumb is the most common.
I don't know. There's something about East Tennessee, long fingers. Maybe I had it too. But the long finger is what I think is most common. But if you look in a doctor book, the thumb. And it's pretty uncomfortable having had it myself. It'll feel like someone is basically squeezing around the knuckle itself. But
can you use your cell phone with that?
You can use your cell phone, yeah. And most people will be able to use their hands without bending their fingers.
Can you shake hands with somebody with a sore thumb?
You can, yes. But that's probably the most common thing, and the easiest thing for it is a cortisone injection. The most recent literature will state that the first injection, probably better than 90% success rate for a lifetime cure. Even if you had it a second time, it's greater than a 72% lifetime cure. So
a cortisone injection, does it hurt? You stick a needle in the finger?
So I'm not a big fan of medicine or needles. I'll be the first to say that, or pain. But if mine came back, I'd take one for trigger finger. Now in other things, say most common painful arthritis in the body is the thumb joint right here. So 25% of people in the world have arthritis right here in the thumb joint that causes pain. More common than knees and hips.
So with the cortisone injection, how long before it starts to feel like Superman's thumb again?
You can get a shot for the arthritis just at the base of the thumb here. You won't like me the next day, I'll be honest with that, but the steroid takes a good 36, 48 hours to kick in. We can put some ice on that, you can wear a brace, but generally after about 48 hours, it starts that steroid medicine after the numbing medicine wears off. The steroid medicine will start to kick in and get the inflammation down, and that's arthritis. I mean, arth is the word for joint, itis, inflammation. It's just a garbage term for inflammation or pain in the joint. Put a little love in there, a little medicine, and that steroid is actually what makes that inflammation subside, and it lets you start to move the joint easier.
So I've seen some patients that have had that, and they said, Oh, I only wish I'd have gone to Dr. Renfree sooner, because they do get such good results with that. Well, let's go to the rest of the hand, the thumb. But I know people that have arthritis in these joints. What do you call these joints?
So the metacarpal phalangeal. So
metacarpal phalangeal.
So these are your metacarpals in the hand, and that extends into the phalanges. So metacarpal.
And the phalanges are?
The fingers, the digits, sorry. So yeah, the metacarpal phalanges are the MP joints. So the MP joints are obviously very important for grip and grasp. If you get arthritis in the knuckles here at the MP joints and even the joints here, you can replace them. That would be my first bet.
But you can eventually if medicine. That's amazing.
So you try the non-operative stuff, and why are they getting arthritic would be my number one question. Is it? We talked a little bit about that. Is it a rheumatoid arthritic patient, which is more of a systemic illness that you can take medicine for? Is it osteoarthritis? That's the most common, where they say wear and tear arthritis. Or is it traumatic arthritis, where someone had a fracture when they were playing football or boxing?
Can gout occur in the hands?
And you can have gouty arthropathy or gouty arthritis.
So there's
psoriatic arthritis, all sorts of things.
So you got to be a smart doctor in order to figure out what it is.
The cause, and if there is a way to make it more stable or fix it, we're moving on and doing that.
So in general, let's just say somebody has metacarpal phalangeal arthritis. How do you treat it? Do you immobilize it? Do you put heat on it? What kind of medicine?
Sure. I mean, at home, number one thing I tell people is they could put a little ice on it. The problem with putting too much ice on the fingers, if you've ever been out on a cold day, in December, your fingers go stark white. You get them in, you run them under some warm water, and they get bright red because you're going to get a big rebound hyperfusion, or your blood wants to flow into the fingers. So you're going to get a little cycle there. So a little cool is good. I like if you can take Motrin or Aleve. I'm a big fan of that. We got a big jug of it at my house. If it's just getting to that point, though, we're taping them together, trying to protect it, avoiding pinching with that knuckle, we can put a little cortisone shot in there, and that's normally how I would start. Non-operative things, because oftentimes a shot maybe 2 times a year, I'm good for that.
I think everybody is good with that. It's when somebody gets a shot once a month.
Correct.
I've heard you say, stay away from that shot a month.
That's once you start getting into that point where you're not getting really good relief with those cortisone shots, if they're not lasting you several months or half a year, or the deformity is getting greater, then you would talk about maybe a replacement. They initially started up in Michigan, where they invented these silicone implants years and years and years ago. Then they've morphed into some other things, whether it's pyrocarbonate or what have you. But generally, those silicone ones were great as we get a little older. The younger people, because the silicone will only last maybe 8-10 years, some of the newer ones are pretty decent, and they give you a lot of pain relief.
I was washing the dishes, don't tell anybody, one time when there was a broken glass and I cut my hand. How do you know when you have a laceration of the hand on either the top or the palmar side, whether you've cut tendons or not, or it just goes down into the muscles or whatever?
Great question. Every time I see my wife doing that, I think, oh, it's Monday morning, 2 people are going to come in from the ER with a cut finger. Again, I think that you look at a lot of these things, and when we grew up, you just put a Band-Aid on it and went about your business. But if you can't bend that finger, if you're seeing pulsatile bleeding for sure, anything in the finger.
Bleeding?
When you see that, when you see the spurts, yeah. If you see that in the finger, you almost have to have cut the nerve, because the nerve lays on top of the artery. So if you hit that nerve, your finger's going to be numb. But I'm more worried about the fact that, hey, I got bleeding finger. I'm not really thinking about the sensation.
Could you lose your finger if you didn't do the right thing, maybe?
If you got it infected, if the wound wasn't closed, if you cut your tendon, there's a timeline there too. You asked that. If you're worried about that and you can't bend that knuckle, you've got about 6 to 7 days to fix that. If you don't get in there and fix that tendon within that time, it's almost irreparable.
So I've seen a couple of people that had that happen, and they said, well, it'll just correct itself.
Nope.
Wrong. If a finger, tell me about the compartments in the finger and how they can be more dangerous than another area if the infection localizes there.
Yeah, no, so like you said, you get a cut, and the number one question is, well, am I up to date on tetanus? And that is something that we seem to forget about here in the United States. You know, that's just a third world thing. No, I mean, there's still some cases of tetanus. So you want to make sure you're up to date, whether that be if it's a bad cut, they say 5 years or 10 years. I'm still a 5-year guy. Want to avoid that. That's not a way that I want to go.
It's an easy way to build up your immunity is get your tetanus shot every 5 to 10 years.
Just get your tetanus shots every 5 years, and then you're covered there. And then you head to the ER if you're thinking you're getting some redness and you ask that question. Yeah, if you get an infection here, that compartment is, as you know, in the fingertip, is very tightly regulated. And if it's an infection in there, it's called a felon, F-E-L-O-N. So yeah, it's a bad thing, and you've got a small amount of time to get that thing actually surgically debrided and cleaned out, so you don't lose that fingertip. If it gets in the tendon sheath, similarly, you got to get that washed out very quickly.
If you see red streaks from infection, is there a chance you've got a flesh-eating bacteria?
Great question.
And that's what we're going to be talking about when we come back. What are the signs of cellulitis? What do red streaks mean? What is swelling up in the armpit, the axilla, from a cut in the hand? What does all that mean? What do you need to do about it? I can't wait to get the answers. We're talking with Dr. Tim Renfree, board-certified orthopedic surgeon, and wow, does he have information. We've already talked about carpal tunnel syndrome. We've talked about arthritis in the hands. We've talked about lacerations. We've talked about the most common arthritis being in the thumb, and it's not necessarily related to cell phones. I thought that's what it was going to be. And now we're going to be talking about infection. We've talked about felons, where it goes into a compartment, and it can be very, very serious. You've got a short period of time. If you see swelling gets bigger and bigger on the tip of a finger, you have to go to the emergency room. And then we talked about red streaks up the arm. And what about, Tim Renfree, the flesh-eating bacteria?
All right, so no question, you get a phone call and you're in clinic or you're at home and they're worried about necrotizing fasciitis, flesh-eating bacteria. What that is an infection. We hear it all the time because it is gruesome. It sounds gruesome. But the reality is when you talk about people that get scared to go to the beach, the number of cases of true necrotizing fasciitis is maybe between 10 and 20,000 in the United States. When you look at ones from the beach, which by the Vibrio, you're talking maybe a little over 200. So we're not talking young people stubbing their toes at the beach often. It's more immunocompromised. But when they call you on people that have
lymphoma,
diabetes, more elderly, but not that you can't get it, but when you're talking about necrotizing fasciitis, the flesh-eating bacteria, you're talking about that whole spectrum of very rapidly progressing infection. And how that happens is it gets underneath the skin, but above the layer of the muscle called fascia, and that bacteria can fly very quickly. And it's most commonly done by many bacteria, multibacterial infection. One is called beta hemolytic strep, alpha beta hemolytic strep, but the infection can progress in 24 hours to the area of your hand, almost all the way up into your arm.
How do you treat that?
If you have to diagnose it very quickly. So that's why when we tell people, hey, I've got this pain in my arm, I've got this streaking up my arm, it could be cellulitis, you got to go to the ER, you got to go to the hospital, you got to call the doctor, you got to go and have that looked at. You have to make sure that what this is not something that's going to rapidly progress, because you truly have, when they look at studies, less than 24 hours over greater than 24 hours, it can be a pretty radical surgical debridement, meaning you're going right to the operating room and having those compartments and having that tissue opened and washed out and started on some very heavy-duty antibiotics.
If usually you get somebody at that phase where you can really do aggressive surgery, which would take a long time, and start IV antibiotics, success rate?
Again, time is time. So if you can get them early enough, in that early stage, when you look at it and you say, oh, it's hot and swollen, should I go to the doctor, should I go to the ER? If it's getting bigger and you have any type of fluctuance or pus, if there's pus coming out, or you see pus underneath the skin, I'm heading to the ER, to the doctor, because that's got to be washed out. Just taking a couple of over-the-counter pills, antibiotics, is not going to eradicate that abscess. You've got to have that drained, and that's got to be taken seriously. The necrotizing fasciitis, just you see it on TV so much that it's a terrible, terrible thing. And that's what scares us so much. So yeah, no, but any infection should scare you. You should, even cellulitis where there's not truly an abscess underneath. So it's just an infection of the skin, and you see that red shiny, or that redness, and it's creeping up your arm, you gotta get that hit with some quick antibiotics. If it develops an abscess, then that's gotta be surgically drained.
So that's very, very important. It's redness, pain, swelling, streaks.
Fever,
that's
chills.
Serious.
That's serious stuff. I still believe that needs to be looked at. And I'm very, yes.
So let's go to that lumps and bumps on the hand. When you see a bump that's as big as half of a marble or even a marble size on the dorsum, on the top of the hand, what do you think of?
So yeah, all of us orthopedists go into it because we love trauma, the trauma and medical school, and you see all that. But the reality is, the bread and butter for a hand surgeon is lumps and bumps. So yeah, you see the little nodules, or you see the bumps on the wrist called a ganglion cyst.
Ganglion cyst. Are those dangerous? Are they cancerous?
No, but you don't.
Precancerous?
But you don't know what they are. So the number one thing people want to know is, well, what is this? Well, you take a peek at it. Obviously, if it's moving with the tendon, it's on the tendon, it's not a cyst. That would be something within the tendon, like tendinitis, or the tenosynovitis we talked about. Could it be something more firm or fixed, a solid mass? Then that would generally be something that you would either take an ultrasound and take a look at. Just take a little wand and see, is that fluid filled?
Yeah.
Is it hard or solid? I mean, back in medical school, they used to close the door and we'd put a flashlight up to it and look at the thing. Don't really do that anymore.
So what's a ganglion cyst or a neurofibroma or a neuroma?
All right, wow, that's good stuff. So the ganglion cyst is coming from a fluid producing area, like a joint. So that's basically it looks like jelly, clear jelly coming from the joint that's lubricating your wrist or your digits. A neurofibroma is a little different thing. That's something that you're getting that's more of a systemic illness, cafe au lait spots, all that stuff.
So if somebody's got a little lump and it's there on their hand, they were worried about cancer, it's most likely not cancer. It's usually going to be what?
More stuff on the hands, you're going to see the most common thing is called a giant cell tumor, or a ganglion cyst. And a giant cell tumor is benign. It comes around the tendon sheaths. But you got to make sure that that isn't something else. And it's very, very infrequent to have a malignant hand tumor.
Oh, yeah.
But you see it, and especially as a hand surgeon, every now and again, you'll see squamous cell carcinoma, which is more of a skin thing.
But I think that's the importance. If you've got a lump that doesn't go away or hurt that's unusual, not going away, it has to be looked by a specialist who can look and know what's going on.
If it's increasing in size or changing characteristics, number one thing, get an x-ray. Is this mass coming from the bone or doing something to the bone? Does it have odd shaped or odd characteristics? Sure. And you can take, like I said, a quick ultrasound or at most an MRI and be able to pretty definitively say, don't worry about that thing, or we need to take a look at that a little more closely.
And remember, if you cut it to get that lump, you better get your tetanus shot every 5 or 10 years. Let's talk about the elbow. I want to talk about tennis elbow.
Right.
My wife had tennis elbow, but she never played tennis. I called it lifting a chair. Yeah. So what's going on with tennis elbow?
So tennis elbow is called lateral epicondylitis or tennis elbow.
Lateral
part of your elbow.
Epicondylitis.
Here's your epicondyle. There's an epicondyle on this side. That's your medial epicondyle. So that's golfer's elbow on this side, and that's tennis elbow. I've never played either, and I've had both. So they call it a rite of passage. It's basically the tendons. Again, tendons attach muscles to bone. So the tendons in the arm over time, and that's why you get it in your 40s or your 50s, is it starts to get little small micro tears, and it is the tendon. So if you MRI'd that, which you don't need to do, you'll see tears in that tendon, but you don't need to treat them surgically. In fact, some have looked and found that if you treat them surgically or non-surgically, they have the exact same outcome in the exact same amount of time.
May take time, takes your time.
Stretching, getting those muscles that are so tight, and that's why they call it tennis elbow, but pro tennis players don't get them. Pickleball players now is the big rave, but and it's caused by just hitting your wrist when it's weak. You also can get it from lifting weights. Tearing sheets in the OR, little silly stuff.
It sure does hurt though when you've got it, and so when you get guidance, you say just tincture of time.
Tincture of time.
Tim Renfree, you are a fantastic teacher. We have covered so much I want to thank you for coming to the Dr. Bob Show. This has been great. My mind's been going just as fast as you possibly can. And so thank you from the bottom of my heart to come first being on the Dr. Bob Show.
Well, thank you for having me. Appreciate that.
Great show. You're going to want to stay tuned because we're going to be talking about vasomotor rhinitis, gustatory rhinitis, infectious rhinosinusitis, allergic rhinitis. All of those are causing a drippy nose. Do you have a drippy nose? Do you know the cause? We'll be talking about that. I want to thank Dr. Tim Renfree. Wonderful discussion on orthopedic problems in the hands, wrist, and elbow. Wow, what a lot of information. And now questions from you, the viewer, that I think will be important to your health. Dr. Bob, what are causes of a drippy nose? Well, the nose can control your life. If you've got an infection in the nose, you can't breathe, you can't taste things. If you've got polyps, you've got a nasal toad. If you've just got a ruddy nose, you have to wipe your nose. You have to be excused from the table to go blow your nose because it wouldn't be very much fun for somebody to listen to you sniff. So let's go through 3 or 4 things that can cause a drippy nose. Number 1 is allergy. So if people have a dust allergy, a mold allergy, pollen allergy in the spring, pollen allergy in the fall, dog allergy, cat allergy, then they have a specific type of nose that runs and itches, and you rub your nose. We call this the allergic salute. There gets to be a horizontal crease on the nose. We get allergic shiners that are right under the eyes. And when we look in the nose, it's pale, it's wet, it's boggy. Another type of nose is when you blow out discolored nasal exudate. So if somebody's blowing their nose and you get a great deal of yellow or green material, that may well be infection. First thing in the morning, maybe not. All day, definitely. So it's usually associated with pain on one side. You don't feel good. You keep that eye closed. If you lean forward to tie your shoes, the head begins to throb. Blood goes to the front of your head and it begins to localize where that sinus infection is. And you pretty much know that you have an infection. So that's the allergic nose. It can be in the spring, it can be in the fall, it can be all year round with dust and mold, and dogs and cats if they're inside the house. So what are some of the other causes? A very common cause as people get older is called gustatory rhinitis. Every time somebody eats, they get a drippy nose. Or when they drink water, they get a drippy nose. Initially, it's when they went to a fine restaurant, and then it gets to be any kind of restaurant, and then it gets to be any meal. And after the meal, the nose gets real stuffy and it gets ruddy. What's going on? Am I allergic to the foods? Am I allergic to a change in weather? That's a sensitive nose. It's being driven by the vagus nerve. Now, when we eat food, the vagus nerve starts digestion. And we don't want it to, but sometimes it sends little fibers to the nose and it causes clear, runny nose, nasal congestion, sniffles. There's great treatment for that. I mean, it's so common that people will always ask, what was the name of that spray? Well, it's Atrovent, A-T-R-O-V-E-N-T, spray, 0.06%, and you spray 2 sprays each nostril. You do it 3 times a day for about 3 days, and then you use it just in the morning, see how long it lasts, and you'd be shocked. It will change your life. No longer will the nose dominate your life. Now, the generic is a name called ipratropium bromide. And so that's really long. Just generic Atrovent, 0.06%. Your pharmacist will know it. They give that prescription all the time. So what is another kind of nose that can be causing problems? Well, we've got infection, we've talked about that, we've talked about allergy, we've talked about gustatory after eating, and then there's vasomotor rhinitis. Now, vasomotor rhinitis is a sensitive nose. So it's a nose that's very sensitive to changes in temperature and pollution. Every time a low front comes through, every time there's rain, well, it must be mold allergy, it must be allergy. No, it's a sensitive nose, and that same Atrovent nasal spray may be magic, or an intranasal steroid spray like Flonase, fluticasone, or mometasone. So all of those steroid sprays plus an antihistamine will do a lot to help you. All the time that we have for this show, remember what we like, those 4 things. Exercise, what does it do? Takes away stress, lowers your blood pressure, helps us lose weight. There's nothing more important than exercise. Eating properly, make breakfast, fruit, fiber, more breakfast than you get later on in the day. 7.5 hours of sleep, how am I going to do that? Easy. Count back from when you wake up. Go to bed at the same time, wake up at the same time. Make the room dark, make it cold. Actually, people say it should be as cold as 58 degrees. Well, I'd have icicles, but still, it has to be a cool room, and you have to enjoy going to sleep. And most of all, what is it we like in the Dr. Bob Show? It's that laughter in your life. You know, if we could take time and we can giggle by telling funny stories, and we giggle and we stay happy, our immune system works better and we'll be healthier.